If you are postmenopausal and on a statin, there is a new study you will want to hear about because it connects cholesterol medication to the kind of memory and symptom burden that most doctors are probably attributing entirely to menopause. That overlap has real consequences for how women get treated. We are getting into it today.
Hi there, I'm Tony Lee, and this is Hot Flasher, your daily menopause podcast that serves up fresh news, research, and wellness tips. I've built a daily news pipeline to find the latest on women's health and menopause research. Allow me to introduce my co-host, Nikki, who handles the headlines. Take it away, Nikki.
Thanks, Tony. We've got a genuinely interesting one today. A couple of brain health studies that connect in ways I want to think through out loud. And a piece of policy news that I did not expect to be covering, but I am glad to. Let's start with statins. A new study just published in Menopause, which is the NAMS journal, looked at postmenopausal women on statin therapy and examined what statins might be doing to their cognition and their symptom load. The headline finding is this: statin use was linked to poorer delayed recall memory, worse visuospatial function, a higher burden of menopausal symptoms, and elevated sarcopenia risk. That is a meaningful cluster of effects. Now, and this part matters. The study did not find an association between statins and mild cognitive impairment. So, we are not talking about statins causing dementia or diagnosable cognitive decline. We are talking about subtler things, the kind of thing a woman notices but might not bring up because she figures it is just menopause. She forgets where she put her keys, she has more hot flashes than expected, her muscles feel off. Her doctor checks all of that against a menopause checklist and says, yeah, that tracks, except some of it might be the statin. This is where I think the clinical implications get genuinely important, and where the medical system is currently not set up to catch this. The symptom overlap between statin side effects and menopause is not incidental. It is significant enough that a clinician who is not specifically looking for statin contributions could easily attribute everything to the hormonal transition. And most 5-minute appointments are not designed to disaggregate that. The question of, could this medication be adding to what menopause is already doing to your body, requires time and attention and a certain kind of curiosity that the standard visit does not always allow for. Statins are among the most prescribed medications in the world. Women are on them, postmenopausal women in particular, because cardiovascular risk increases after menopause. So this is not a niche population. This is a lot of people, and the statin question deserves a place in the conversation their doctors are having with them. If you are on a statin and you have been chalking up memory blips or increased symptom burden entirely to menopause, this is worth raising. Not to stop your medication, cardiovascular risk is real and statins save lives, but to have a more complete picture of what might be contributing to how you feel. The APOE4 story is a different kind of complexity, and I want to spend some time on it because I think it is going to matter more and more as genetic testing becomes more common. A study published June 19th, brand new, looked at what happens to the brain's blood vessels and mitochondria when APOE4 carriers go through the hormonal changes of menopause. Specifically, it found that the APOE4 genotype negates the protective effects of ovarian hormones on cerebrovascular, endothelial, and mitochondrial function. Unpacking that, estrogen, while it is present, appears to have protective effects on the blood vessels of the brain and on how those cells generate energy. That protection is part of why the timing of hormone therapy matters. The window of opportunity hypothesis, the idea that starting HRT earlier in menopause may be neuroprotective, is built in part on this biology. But APOE4 which is the strongest genetic risk factor for late onset Alzheimer's disease, appears to interfere with that protection at the cellular level. Carriers of APOE4 may not be getting the same benefit from their own estrogen, and by extension, possibly not from exogenous estrogen either. This is a preclinical study, so we are not yet at the point where a clinician can translate this directly into a treatment decision for an APOE4 positive patient. The research is establishing mechanism, not clinical protocol, but it is important because it complicates the simple version of the HRT is brain protective narrative in a way that the evidence has been gesturing at for a while. The population of women who carry APOE4 is substantial. Roughly 15 to 20% of people carry at least one copy. And right now, most of them do not know it because genetic testing is not standard in menopause care. If you happen to know your APOE4 status and you are thinking about hormone therapy partly for brain health reasons, this is a study worth bringing to your doctor. The kind of evidence that ends up on tools like open evidence, the clinical decision support tools that physicians actually use, is exactly this: mechanistic research that changes how we think about who benefits and how. My honest take on this one: I think the APOE4 finding should accelerate the conversation about personalised menopause care, not in the wellness grift sense, not the $400 genomic hormone kit sense, but in the legitimate clinical sense. Knowing that APOE4 carriers may not respond to estrogen the same way other women do is the kind of information that should eventually change what gets measured and what gets discussed at a menopause appointment. We are not there yet, but this is the research that gets us there. The news item I did not expect to be talking about today. Washington State. Governor Bob Ferguson signed an executive order directing state agencies to support employees who are experiencing perimenopause and menopause in the workplace. I am going to be honest about what we know here. The full text of the order was not included in the source material I have, so I'm not going to speculate about the specific provisions. What we can say is that a sitting US governor signed an order specifically naming perimenopause and menopause as a workplace issue requiring official support. That is not nothing. The UK has been further along on this for a few years. There have been workplace menopause policies, tribunal cases where women argued they were dismissed because of menopause symptoms, and growing pressure on employers to treat this as the occupational health issue it is. The US has lagged behind that conversation pretty significantly. Most American women navigating hot flashes, brain fog, and sleep deprivation at work have done so without any formal acknowledgement that this is a medical reality affecting their performance and their well-being, and without any structural support. An executive order covering state employees is a limited scope. It does not cover the private sector, and Washington State is one state. But policy tends to move by demonstration. Someone does it, it works, others follow. Or, at minimum, it becomes harder to argue that nothing can be done once something demonstrably has been done. What I would want to see in an order like this: flexible scheduling that acknowledges that a woman managing severe vasomotor symptoms or sleep disruption may need accommodations the way any other medical condition warrants accommodations. Access to cooling measures in the workplace. Menopause literacy training for HR and managers, not optional wellness webinars, but actual education on what perimenopause and menopause can look like in a working adult's life. And ideally, insurance coverage for menopause-informed care that does not require a woman to fight her provider for it. Whether this order delivers any of that, I genuinely do not know yet. But the fact that it exists at all means someone in a governor's office decided this was worth the political capital to sign. That is a shift worth noting.
Thanks for listening to Hot Flasher. We're back tomorrow with more, so don't forget to subscribe. See you tomorrow.